couldn't make it today. But that means like I need all of your help. So please definitely put your thoughts in the chat. If you are able, I'll come to you for some input as well, so we can tag team it together. Um, so I think Bettina have a case. Bettina, do you want to say hi to everyone?
Yeah, hi everyone. I'm so excited to present my case today. I'm so excited to see all of you. And I think I see some people from the Philippines as well. So I'm from the Philippines and I'm really happy to see you guys joining today.
Oh my gosh. Philippines is one of the countries on my list of places that I want to visit. So I will, whenever I do that, I need to get some recs from you all. All right. Okay, doke. So if you all don't mind pulling up the board, we can get started. Okay. All right. Bettina.
Okay. Okay, let's start. Okay, so I have for you a 41-year-old male coming in for muscle stiffness. So you want to pause there or I could go on?
Do you want to just give a little bit more information and then we can
Yeah,
talk?
yeah, sure. It's just a short history. So, actually, one day admission, the patient experienced stiffening of all four of his extremities for an hour, after which he noted spontaneous resolution of his symptoms. But later that day, he experienced numbness and tolerable pain on his extremities. And then a few hours prior to admission, the patient then woke up from his sleep due to the recurrence of muscle stiffness of the same characteristic in the same all four extremities, still with numbness and tolerable pain. And so the patient was brought to the emergency room. So,
All
yeah.
right, this is fantastic because I really don't have that great of a schema for muscle stiffness, so we get to build that together. So, and he was like 40 years old, correct, Bettina?
Yeah, 41.
Okay, 41 years old, who's like coming in with what kind of sounds like intermittent muscle stiffness that involves all of his muscles. Female. So I think whenever I get a complaint that I'm not as familiar or don't I have as built schema, then the question I think about the muscles themselves and what it takes for them to be able to function. Right? Is there any issues with uh, electrolyte derangements, right? Your muscles need their potassium, they need their calcium to be able to function. So, is this muscle stiffness any related to electrolyte imbalances? Is it a toxin mediated process that inhibits the receptors from being able to function and for the muscles to become stiff? Anything that causes them to be contracted, and that can do it as well. Thinking about more like neural access as well. If this is something with neural access that we're dealing with, or is this something with the muscle itself? You know, infections that can cause some toxins, neurotoxins. So all of these things are things that come to my mind. So one thing that I would be very curious is to help better define the syndrome. Right? Is there any other features like from fevers, inflammation, any exposures that this patient has had that is causing her to feel stiff. And the exam would be really, really helpful to better to have a semantic qualifier or better understand what this stiffness is. Is it like fasciculation? Is it an inability to move? So I think exam would help shed light and actually like how are we gonna qualify it stiffness in our medical term. All right, Bettina, back to you.
Okay, great. That was an amazing discussion to start us off. Okay, so actually our review system showed that the patient was also experiencing palpitations and tremors. The patient also had a noticeable weight loss for the past few months, but he did say that he was practicing intermittent fasting, so he attributed it to that. The patient's bowel movements were noted to be 3 times a day, but for him, it was normal already. It has been that way for years. So for him, that was normal. And then the patient has no fever, no headache, no dizziness, or blurring of vision. And then, do you want me to move ahead to the past medical or?
That sounds
Okay, great. So the patient is a non-hypertensive. He is currently taking telmisartan and hydrochlorothiazide, and he has an allergy to crustaceans. For the family history, he has a family history of hypertension for both the mother and the father side, and then hyperthyroidism from the father. And then the patient is a previous smoker. So in total, it was a 7.5 pack years. He is an occasional alcoholic beverage drinker. And again, his current diet, because of the thing he practices, then his usual meals are actually a large amount of carbohydrates because he's a Filipino and he loves rice so much. So he has a lot of that in his meals.
All right. This is such a fascinating case, Benjina. Thank you so much for presenting. So, kind of going back to his other symptoms of, weight loss. So, whenever I think about weight loss, that it seems like, it's unintentional on his part. Is that, if there is any condition that is going on that increases the demand in the body that leads to weight loss, something like from hyperthyroidism to aggressive cancers that can cause a lot of weight loss, any indolent infection that causes increased demand in your body. So that is like my always like biggest worry is like increased expenditure of energy that then requires to for your body to use all its store that is not matched by your intake. And it sounds like, he's eating really well. So that is like the part that I'm most worried about. And the 3 bowel movements a day, I think thinking about like, oh, is it like very loose, loose or watery? Then we can like try to invoke more diarrheal symptoms. Or if it's just like still very formed and 3, like I'm less worried about diarrhea contributing. So I'll just make a note of that he's having those symptoms and see if there is another signal that the GI tract is also involved. In terms of like one thing you mentioned about intermittent fasting and high loads of carbs, one thing that comes to mind that usually presents with like flaccid paralysis and not so much, if I remember correctly, with like stiffness, is a condition called like hyperthyroid induced periodic paralysis that is usually potassium mediated. That hyperthyroid state makes your makes like your state to be very sensitive to like an adrenergic state or insulin. So what happens is that when you have a big load of food that stimulates your insulin to go high, then insulin, what does? It like pushes potassium, for example, into cells that causes like this periodic paralysis, then that with time usually gets better. Some patients will tell you that like, hey, these things happen and then like I eat a banana and I'm totally fine. So that is like the carb loads plus like this episodic episode kind of reminded me of that. But however, we're not there to do to be able to put our nickel down. So I think we still need to better figure out what the actual problem is that we're trying to solve. Like, what is this muscle stiffness on exam, and go from there. The other thing that I would mention, like, with medications, like losartan hydrochlorothiazide, is that these medications tend to have electrolyte side effects. That's another thing that I know that I will note, that he's just like more prone to those. However, I think we need the exam to better define the problem we're trying to solve.
Okay, so let's move on to the physical exam. So our patient was awake, coherent, and not in cardiorespiratory distress. Vital signs, BP was 130 or 80, heart rate was 99, respiratory rate was 20, temperature afebrile, and O2 saturation was 99% at room air. So head and neck exam was unremarkable. Cardiovascular and respiratory also unremarkable. Abdominal as well. For the extremities, there was no lower extremity edema. Extremities were warm and well perfused. No deformities or lesions noted. For the skin, there were no rashes and no lesions noted. And then for the neurological exam, the patient an appropriate mood and affect with a manual muscle testing of the upper and the lower extremities of 0 out of 5. So it wasn't moving at all. And reflexes were normal reflexes. Yeah, that's it for the physical exam.
Benita, just to make sure I understood correctly, so his lower extremity was 0 out of 5 bilateral, and there were no reflexes.
The reflexes were normal. Yeah.
Okay, the reflexes were normal.
Yeah.
Okay, gotcha. And the upper extremities were fine.
The upper extremities were also 0 out of 5.
Okay, so okay, gotcha. So bilateral upper and lower extremities, 0 out of 5 with intact reflexes.
Yeah.
Okay, cool. All right. So fascinating. So so with everything just starting in the vital signs, the patient is starting 88%. What is that true? 88?
It's 99%.
Okay. And I was like, oof, we have hypoxemia, we have muscle weakness. Now I'm really, really nervous. So thank you for correcting that. So that, and again, like that's the thing that when I heard the neuro exam, the first thing I wanted to go back and double check was like the oxygenation level, because the question is, whenever you're dealing with a type of a paralysis that involves the diaphragm as well or not, and usually with the diaphragm involvement, people become hypercarbic, and as hypercarbia progresses, they can get altered and more hypoxemic, and that is that is a person that you want to put in the ICU. You have to think about intubating. Thankfully, this is not here, we're not there yet, but this is someone that to watch their respiratory status very carefully. This is someone that you might want to ask your respiratory therapist to see and to do a MIF test to kind of check their ability of diaphragm to do its work. So that is like something to prioritize in evaluation of this person, is looking at their respiratory status. So, the other things to think about, a skin exam to make sure there's no tick bites here, to make sure there's no other rashes or thing in this case, that would be helpful. And then let's come to the neuro exam, which is the bulk of it. So this patient have a bilateral upper and lower extremity, kind of sounds like flaccid paralysis with normal reflexes. So then the question becomes like, where in your neuro axis are you localizing that? Like, in terms of like, starting from your bilateral hemisphere to your spinal cord, anterior horn cells, roots, peripheral nerves, to your neuromuscular junction, and then muscles. The one thing that it sounds like, it wasn't mentioned, but it sounds like the sensation is intact. If I'm correct in making that assumption. So I sometimes one thing that I always want to make sure whenever I see a bilateral upper and lower extremity, that is not a C-spine pathology, because like an acute C-spine pathology. So make sure this patient didn't have any traumas. So that is like one diagnosis to think about. But oftentimes, you'll have also sensory losses as well. So it would be hard to get bilateral upper and lower extremity unless like as at a level of diffuse, at level of the neuromuscular junction or the muscle. So that is where I'm most worried about for this patient, is that, are we dealing with a neuromuscular junction disorder, or are we dealing with a muscle disorder? Sometimes like with other diseases like anterior horn diseases, like with ALS, you can have both upper motor and lower motor neuron. as well. But I would say with this person, I'm more worried about the neuromuscular junction. So thinking about, your Lambert-Eaton's myasthenia gravis, and then the muscle issues like the myopathies. I don't get a sense of any inflammation in this patient. So I think like we kind of mentioned periodic paralysis. Um, so that is something that I'm still worried about. So thinking about now more of a neuromuscular junction and then any muscle um, issues. And I will look through a chat as you, Bettina, give us a little bit more information to see what else people are thinking.
Okay, I'll get started on the initial labs moving forward. And yeah, I just wanted to clarify that yes, the sensation was intact in all extremities. Okay, so for our labs, for the CBC, the hemoglobin was 14.5, the WBCs were 9.5, platelets 233, neutrophils 76%, and lymphocytes 16%. And then the creatinine was 0.7, and then BUN was 40.57. And then our electrolytes, we have sodium of 142, and then potassium of 1.8. Our urinalysis was normal. And then we also have the CK of 242. And then we also did an ECG at the ER, which showed a second degree AV block type 1. And then we also have VBG findings. So the pH was 7.3, 7.35 to be specific, PCO2 of 41.7, PO2 of 55.6, and bicarbonate of 23.6. So I just have one last lab to give. So maybe after the discussion.
Yeah, absolutely. All right, what a right team. I also want to say that I've only had half of my coffee this morning, so I'm doing this half caffeinated. So my apologies for being a little all over the place today. So kind of looking through the labs, the thing that jumps out, and I think everybody's like commenting on it, is the hypokalemia. So let's, now that we have a little bit of time, let's just think about hypokalemia and how you all think about it. So I think like I want to have like a practical approach to hypokalemia that is, most common etiologies is your GI symptoms, meds, and hypomagnesia, right? GI symptoms, vomiting, diarrhea can definitely contribute. And that's the thing we most commonly see. Meds like our diuretic, especially like your loop diuretics, and then insulin, albuterol, especially like with albuterol, like continuous use is the one that I associated most with, and hypomagnesia. So those are like the most three common causes of hypokalemia, which I don't think we're dealing with. So we're dealing with one of the more esoteric one. And with that, oftentimes like the pH is the one that helps me the most. If it's low, normal, or high. If it's low, I think about like if the patient has acidemia as well, then I think about RTAs. If it's normal, I think about channelopathies. And if it's high, then, I think about more the kidneys. So if the patient has alkalosis, then think about like Barter-Gilman, that kind of like it's exaggerated, almost like having a loop or thiazide on board, or inappropriate aldosterone excretion. With the pH of like 3.75, that is like kind of like 3.5 to 4.5 for me is like kind of normal. It kind of fits with a channelopathy type of a picture. So in terms of like what to do with that potassium, right? One thing that that was important that Bettina mentioned is like getting an ECG right away. Your heart muscles also need the potassium to function, and the patient already has a second degree AV block. So the one thing. So one thing to consider is so one thing to consider is like, oh, I want to replete this. I would caution to be careful with that. If this is a channelopathy or it's the hypokalemia, it's due to shift. some of this potassium might be inside the cell. So the tendency is to see that potassium and give a lot of potassium, but as the trigger for the shift goes away, those potassium is gonna leave the cell. So you want to be careful with giving too much potassium, especially if you're concerned about a shift. So I would start with a small amount of potassium first. Um, just to kind of summarize what are we worried about, we talked about hypokalemia. And when I think about hypokalemia, I think about what is the most common first, your GI symptoms causing hypokalemia, your medication side effects, and then hypomagnesia. So it's a good idea to get a MAG here as well. And those three tend to be the most common causes. Once I've thought about those, then I think about like my second pass. My second pass would be looking at the pH and deciding whether this patient has acidemia as a normal pH or alkalemic. Because then that helps you locate where the problem is. You know, with acidemia and hypokalemia, your renal tubule acidosis rise up. If the patient has alkalosis and alkalosis and hypokalemia, then you worry about Bardet-Gittman syndrome or Bardet-Gittman syndrome, and then or inappropriate aldo. If the pH is around normal, then you worry about channelopathies. And these type of channelopathies are usually people is genetic. So people are more prone to have issues with the channels that help shift potassium and sodium across the cells. And then another trigger comes along that makes potassium want to go into the cells. One of the most common causes, and someone who has a background of some GI symptoms of weight loss, hyperthyroidism. It's hyperthyroid periodic paralysis is an entity that these patients are prone to. So what happens with like the hyperthyroid state is that your adrenergic state is high, and then you are more prone into like effects of like insulin. So if you have a large carb load, and what happens is that it stimulates insulin to get increased. And once the insulin is in, what does insulin do, right? We give it when people are hyperkalemic. So insulin shifts the potassium into the cells, and then the patient is the whole body-wise has normal amount of potassium, but now most of the potassiums are in the cell. So that is the lab work that I would get next, would be a TSH level to see if this patient is a hyperthyroid. And what you want to do is like give a little bit of potassium if the patient is hyperthyroid, and then do your hyperthyroid treatment. This is a patient like I would get help from an endocrinologist to make sure that we're doing all the right thing. Because if you address the underlying cause of why the shift is happening, you will fix the hyperkalemia. The other thing is like this is a patient who requires a high level of care, both because of the respiratory status and frequent lab checks and also cardiac monitoring. So this is someone that I would want to be in an ICU, for example. All right, Bettina, do you want to give us information?
That was incredible. I think you were able to clinch the diagnosis already. So as mentioned, our last lab is actually the thyroid function test. So we have a TSH of less than 0.01. We have an FT3 of 12 and FT4 of 3.14 is elevated.
What a epic case, Bettina. Thank you so much. I love this entity because it really makes you have to think about pathophysiology in order to be able to treat this patient correctly. So this patient has a hyperthyroid induced periodic paralysis that is hypokalemic mediated. And the treatment of that is to treat the hyperthyroidism, and also just make sure you replete enough. There are a really good algorithm, if you don't have like access to an endocrinologist, that tells you you don't want to like really replete. I think more than like I don't remember it, like there's a certain amount of potassium in a day that you want to give, no more than that. And this other patient who really use a propranolol, and then you want to, if you don't have any contradictions, to start a methimazole early and up titrate. And the beauty of it is, for most of these patients, once you fix the hyperthyroidism and they're on the medication, these episodes tend to not happen, because it is the biggest trigger is the hyperthyroid state. But you want to also make sure you do very well education. So like some of these patients, especially in the hyperthyroid stage, like exercise can do it too, because you get a lot more like beta agonism with that. Any like severe stress, exercise, and insulin, whatever that causes increased insulin, like carb loads, would do it. So it's good to like stay away from that. Bettina, do you want to tell us a little bit more about what you learned, and also how did the patient do?
Yeah, of course. So just a little bit about the diagnosis or not diagnosis, paralysis, which was probably secondary to Gray disease. So that was what was worked up in the patient as an outpatient. So actually, thyrotoxic periodic paralysis is a rare endocrine disorder that is usually characterized by this triad of thyrotoxicosis, hypokalemia, and acute muscle weakness. That is actually usually encountered at night. And then it's usually common in males and people of Asian descent. So it's so interesting when you look for case studies about TPP. I've seen a couple of them that are actually Filipino. So that was very interesting to me. And as mentioned by Charmin, high carb loads and vigorous exercise are actually known triggers for TPP. So our patient was given potassium infused fluids with eventual increase to 2.2 and then later 4.9. And then actually on the 4th hour of correction, the manual muscle testing was already noted from 0 to 3. Then on day 3 of hospital stay, when we went to the patient, he was already walking around in his room. He was jumping and he was so happy to recover from it. And he was also given propylthiouracil. Yeah.
Amazing. I'm so glad the patient did well, and thank you. And thank you for reminding me that I kind of stopped at like, oh, hyperthyroidism treated, but yes, most of these cases are Graves. Thank you so much for reminding me that there's always another why in medicine. So why does this patient have hyperthyroidism? We weren't done yet. So thank you so much for mentioning that. And thank you all so much for all the incredible comments in the chat. And I think Noah, thank you for putting in the protocol that is about 30 milliequivalents of oral potassium every 2 hours until improvement begins, and the max is about 90 in 24 hours. So thank you also so much. Sorry I couldn't come to the chat as often as I wanted to, but I really appreciate all of your inputs, and I can't wait to catch up with that. Yu-Teng, I'm so excited for your teaching points.
Hi everyone. Thank you so much, and thank you for this amazing case. And here are some teaching points. So this patient came with the chief complaint of muscle stiffness. So when it comes to the muscle stiffness, the first thing we have to ask if this is a problem with electrolyte such as potassium, or is it toxin mediated, or this is all is only muscle, or also is something neurological. So also we need to ask some additional questions to the patient if there's some possible cause of infection, fever, or any sign of infection. So of course an adequate physical exam is also warranted for this chief complaint to ask if this is a fasciculation or is tremor. So Dr. Sharman also mentioned about something called hypokalemic thyrotoxic periodic paralysis, which is characterized by three things, which is thyrotoxicosis, hypokalemia, and acute painless muscle weakness. And also think about when it's related to muscle, think of hyperthyroidism, and hyperthyroidism is involved the adrenergic state is high, and they can cause the muscle stiffness. And also think about in these patients, the history of hydrochlorothiazide and can induce hypercalcemia and also hypokalemia. And some of the causes of neuromuscular junction that was mentioned is ALS, myasthenia gravis, and also multiple sclerosis. And causes of hypokalemia, we mentioned about the most common will be GI symptoms such as vomiting, diarrhea, and some of the meds as insulin, albuterol, and also state of hypomagnesemia. And we are also worried about if this is the hypokalemia, if it's due to a shift, the potassium can be still inside the cell. And then we have to be careful with the treatment with the potassium. And also we have a great schema from clinical problem solving about the hypokalemia and the most common causes, and that are based on the pH level. As mentioned, if the pH is low, we think about acidemia, so we think about the RTA, can be RTA 1 or 2, and for the lower GI, we think about the causes diarrhea and laxative. When the pH is normal, so we think about a low level of magnesium, which would cause a cellular shift, and that can be increase of insulin, beta agonism, such as albuterol, as mentioned, hypothermia or channelopathy, which is a periodic paralysis or variant toxicity. And if the pH is high, we think about alkalosis, which can be a loss of chloride, or there's no loss of chloride. So each one of them have their classification as well. And we also mentioned about another of the symptoms that this patient had, which is weight loss, and that also match with the high demand that is proper of the hyperthyroidism, or also we think about a state of cancer. So for this case, the management is hyperthyroidism, of course. So we have to treat with fluid, with potassium, and also PTU. And that is all my teaching points.
Wow, that was amazing. Thank you so much for that great teaching point. And Mohammed, thank you so much for describing Bettina. Thank you so much for presenting such a wonderful case and for you all to joining in. This is the best hour of the day for me. So thank you so much. I can't wait to see you guys tomorrow. Thanks all. Bye.